So welcome along to tonight's Diabetes Chat. Myself, Tom, as the host this evening, and we are in great company tonight with Michael Harris and Natalie Bellini as our guest speakers. Looking forward to tonight's chat, talking about diabetes and psychology of diabetes. And we welcome Michael and Natalie to the chat. Thank you for coming on, and it was lovely meeting you both before we actually do a little intro and go round. It was really nice to see you both at ISPAD. That's where we met, and I don't know, you may remember, I was the guy that stood up and asked that question at the end because I was just blown away. I was like taken away by your incredible session, and I was like, we need to reach out and get you guys on because it was so fascinating. No, it was really good, wasn't it? Mm, 100%. 100%, yeah, yeah. And how good is it to be at these international global conferences, but to have people with diabetes or people like with DDoc, for example, it's just phenomenal, isn't it? That we're there, like able to listen in and report back and chat and network and learn together, because that's what it's about, isn't it? It's not just you guys doing all the incredible work, but us being there, like we can then chat and learn from each other, right?
We are.
100%.
I absolutely agree. I mean, I think that I don't remember which organization first said we're going to invite, they call them the social influencers, the bloggers, whatever. I mean, I think, Michael, I think it was ADA. Was it not? I don't remember. And they've hosted these ever since, and other meetings have picked it up and said, you're right, don't do this. Renza, who's our very good friend out of Australia, has always said, no, nothing about us without us.
100%, yeah. Nothing about us, yeah. Yeah. We have to be at the table, and you know what I mean. We're not hiding in the background. We need to be at the table and bringing our voices and changing things together, changing diabetes care and how it's shaped and policy, and you know what I mean. That's you know what I mean. It wouldn't be worthwhile just sitting in the background. Like, utilize us as work together collaboratively, right?
Very much so.
Brilliant. So what a fantastic little chat to start off. But I think what'd be nice is if we start with you, Michael, and then Natalie to follow, is could you just next couple of minutes just introduce yourself to the community and to the podcast listening back, is who you are, your connection, your role, and what fascinates you about diabetes?
Yeah. Thank you. And thank you all for having me. I once again feel honored anytime I'm included in this group. I'm not a full member, but I feel like I'm about as close as you can come to being a member. So thank you. So in graduate school, I was assigned a advisor. And at the time, I didn't know anything about diabetes. She happened to be doing research in diabetes and was living with diabetes. Her name is Cynthia Hansen. And I just became incredibly fascinated by the complexity of diabetes coupled with kind of where the research was at. And it seemed like there was a huge gap in the psychosocial and behavioral aspects of the science. And so she took me under her wing and, taught me a few lessons about living with diabetes and where the research kind of has fallen short. And one of her main lessons to me was that most of the research at the time, this was 30 years ago, in type 1 diabetes and the psychosocial and behavioral functioning, was that kind of using the deficit model, meaning that there must be something behavioral or psychosocially wrong with people who are living with this condition because it is all consuming.
Mm-hmm.
And she encouraged me to take a strength-based approach and rather than look for the pathology, look for the strengths, look for models of how to build strengths and resilience in this population. And so I really never forgot about that as a key component of what I do. So along the journey, I was at WashU in St. Louis, Missouri for about 15 years as an NIH-funded researcher. And then I moved to Portland about 18 years ago. I'm the chief of pediatric psychology. I work in our Harold Schnitzer Diabetes Center, seeing patients a full day a week. So I continue, even though I have other demands on my time, to continue to see young people living with type 1.
Yeah.
I both publish as well as see patients, and then I developed a program called Niche about 13 years ago, Novel Interventions in Children's Healthcare, and that was really targeting the most vulnerable living with type 1. So those who have incredible social burden come in for repeated DKAs, and the medical center and the medical institution really doesn't have anything to offer because the challenges are social in nature. And so that has been really the focus of my attention and really the love of my life going since I started the program 13 years ago.
Thank you so much, Michael. What about you, Natalie? A little background to you.
Sure. So I am a nurse practitioner. I am an assistant professor of medicine at Case Western Reserve University here in Cleveland, Ohio. And I'm the program director for diabetes technology at university hospitals here. We follow about 65,000 people with diabetes. Obviously, I don't see them all. Inpatient, outpatient. And I see patients 3 to 4 days a week in clinic still. I do some research. I do some teaching. I do all kinds of technology. I've taken a role in helping with creating a screening program here for the screening for first degree relatives of people with type 1. So that's been a huge undertaking in the last year or so. And I do live with type 1 diabetes, as well as my husband lives with type 1.
And when were you diagnosed, Natalie?
A very, very, very long time ago. After you get to 50 years, you don't have to tell people anymore how long it's been. That's what I tell people. So once you hit 50, you don't have to talk about it. How's that?
There we go. Have you got the medal? Have you got the award?
Yes, someone gave me a medal. Yes.
Brilliant. And how long about your husband? How long has he had type 1? Is it similar time?
He was diagnosed. No, he's not even close. He's a youngin'. He was diagnosed at the age of 20.
Yeah.
So I have almost 20 years on him.
Wow. And what's it like both living with type 1 diabetes? Is it, especially bringing it back to sort of the psychology element of it, the mental health and stuff like that, is it nice to have someone who can really, really understand? And I know you'll get what I mean by that. Like my wife, she's really good. She's really knowledgeable. I've got a good diabetes team, which are great and knowledgeable. But the people that really get it are the people who are listening in this room tonight and listening back, who are the ones going through exactly how we're feeling day in, day out, 24/7, right?
So I think that's true to an extent. I think also sometimes things are, what you say could be perceived differently, right? So one time he, and this is before CGM even, right? We've been around a long time. He checked his glucose and I could see it in his face. He was like, oh, and I said, what's wrong? And he said, oh, my blood sugar is whatever, right? If I do a UK translation, it was like 13.5, right? And I looked at him and I said, why are you high? And he looked at me, and there's like this silence. And my husband is very dry sense of humor, so you'll appreciate this. He said, well, one day about 20 years ago now, my pancreas up and quit on me. And so I don't make insulin anymore. And I have to do a really good job of guessing on how much to take. And sometimes I'm dead on and I'm a hero. And sometimes I'm not and I'm a failure.
Yeah. Yeah.
Yep. And I didn't mean it like I meant, how's your infusion set? Do you, right? Like, do you need my help? Do you want some water? But it didn't come across that way. It came across as judgmental.
Yeah.
That's really hard.
Yeah. And that's why nowadays, like you've mentioned Renza and Jazz, Jazz Seffi and people like that, who are in the movement of ensuring that language matters is so important, isn't it? So
right. And the language wasn't meant to be
no, exactly. It can be interpreted, and that's
yes.
And that's two people in the same household who are married, and these things can happen.
Who both understand the disease, right?
Yeah.
Like we both understand it, right?
Yeah.
And I crushed him, and I didn't mean to crush him, and he put me back in my place as he can do, right? And it was just wow, I am so sorry I hurt your feelings. Like I did not mean that. All you can do is back up and apologize, because you know what it feels like when you failed twice. You failed because your blood sugar's high. Right? But it was never meant to come across that way.
No.
But I will tell you that even when we're trying together, and we both do understand what it's like to be high or to be low, right? On a better note, like we have a policy where if one of us is high, we won't eat. We will go for a walk instead and then eat together, right? Like, so there is some
solidarity,
right? Right. So there's some solidarity in it all at the same time, right? So I think there's a both. How's that?
Yeah, absolutely.
But I don't want to think that people think that just because I'm married to someone with diabetes doesn't mean I can be or come across as a jerk, right? Like, I mean, he was like, "Thank you, my pancreas doesn't work." Yeah, I know. I'm an expert in this field, right? But it certainly made me understand how my tone came, at least in his ears, right?
Yeah. No, I really get that. So can I ask then, you guys, over where you are, is seeing a psychologist and having mental health support, is it offered for the sort of diabetes care? So we talk about quite a lot on here, like we believe that when you're diagnosed with diabetes, you should have that toolkit. You know what I mean? You should have the treatment. So whatever the tech, or like you mentioned tech already, guys, like the CGMs, the pens or the pump or whatever, you should have the education. So all the education you need to treat your diabetes and manage your diabetes. You need peer support, because we know that it's good to have people who are going through similar things. It's good to be able to talk and share and connect with people around the world, and also be there in times of when you can't get hold of your diabetes team, or we only see our team for a short amount of time. And then another aspect of it that we talk about is the mental health and having access to services like that. And in the UK, we find in the PED service, it's more available or readily available. And as you sort of transition into young adults and into adults, it's not as available. Well, is it the same with you guys, or is it available at all ages?
So in our diabetes center, there's 2 psychologists with some effort in the diabetes center on the pediatric side, and 1 psychologist who's a full-time psychologist on the adult side. I see every new onset young person in our hospital. So at diagnosis, I go over to the hospital, introduce myself as part of the care team, kind of destigmatize the role of a psychologist in diabetes care. Nothing to do with them being now mentally unhealthy because of diabetes. And that's a really important kind of beginning point for most of the young people that I see. On the adult side, I know our psychologist tries to, for any young adults who are diagnosed, in their 20s, do the same thing. And then we're supposedly part of the comprehensive care model that we provide. in our institution. The problem with that is that I think people forget that, providing psychological, mental health support, behavioral health support is best used on an ongoing basis as opposed to just putting out fires.
Yeah.
And so rightfully so, they come into the diabetes center to get their diabetes taken care of. And they don't think to schedule, just for a check-in, if you will, to see one of the psychologists. And so what we end up seeing a lot of is young people or adults who are already at the point of really struggling. And I don't mind trying to put out fires. Frankly, I don't know that I have the skills at that point when somebody's, really knee deep in some of the challenges of living life with type 1 diabetes, because there's just so much going on at that point. And so providing care in a clinic seems really
but we shouldn't have to get
limiting.
to that. We shouldn't have to get to the point of.
We shouldn't have to get to that point. And
No.
so the idea was that, once again, that we have regular check-ins when they come in quarterly or semi-annually for their visits with the educator and with the endocrinologist, that they would see us as well. Unfortunately, that isn't happening. And so we continue to have a reactive model, if you will, around behavioral health and mental health when it comes to diabetes, and are seeing people who, are already really struggling with managing their diabetes. And I wish I could have seen them, months ago, where we could have short-circuited some of these challenges.
Definitely. Let's bring Natalie in as well. But for me, like, I was diagnosed 18 years ago, and for 15 of my years, I didn't accept my diabetes. I blame myself. I would just put my head in the sand basically, and just hate myself for it, and avoid it, and not sort of take it on, and allow diabetes to control me. And I was 17 at the time, so I was a young adult. I was about to go to uni a year or so later, and do you know what I mean? At that age, you're starting to go out and be with friends and all them sort of things, and it was tough, and I didn't have any of that support, and then went into my 20s, and I just wish I had that support. And I had masses of diabetes burnout without even know what the hell it was, and I wish I had that support. And I think even if it was a one-off session, that would have been better than nothing. But I totally get what you're saying, Michael. Is personally, I think it's that ongoing support. I personally think it should be part of the package. Like I said, the toolkit, that you have your annual checks of your bloods and your consulting appointment, etc., your nurse and your dietitian maybe, or your feet check and your eye check. But personally, I think you should have an opportunity to go have like support in psychologists personally. What about you, Natalie?
Can I just say something about that?
Yeah, go for it. Yeah.
So the problem isn't the problem is that humans generally respond to acuity, and so if they're doing okay and they're managing okay, then they're less likely to address whatever it is that is in front of them.
Yeah.
And they usually wait until there's a high level of acuity, and then they come in. So I think it's human nature not to see someone like me on a regular basis. Unfortunately, it's problematic. If you had a young child, if you have young children, about well child visits, and in young children, that's the rate of attendance on those is quite high, because we see that as such an important piece of just not waiting for them to have any problems. Is we want them to see a pediatrician on a regular basis early on in their life, make sure that all spheres of their life are going well and that they're meeting all the milestones.
Yeah.
That's really the only time people get kind of regular preventative care. And so when it comes to behavioral health and mental health services around diabetes care, it's just natural that people don't think of that as an integral part of their care.
Yeah. And I think it also goes back to me as well. We've talked about it on here many times on Diabetes Chat, and I think you'll probably talk about it in your little session soon, is is that when you go into appointments with any diabetes team, is to focus on the person in front of you and see them as a normal person, like an everyday person, and how are you, how's things, how, you know what I mean, rather than just going straight into diabetes mode of checking, oh, look at the numbers and and data, and you know what I mean. I think that doesn't help people. I think you need to build that trust. So if you're not getting the services like seeing a psychologist or having referrals to go check out this resource or do this, do that, is just the basics that when you go see your diabetes team, is that they're implementing these strategies to promote good mental health. Do you know what I mean by that?
Very much. Yeah, in our institution, on our pediatric pain team, so young people who have recurrent and chronic pain, we have a fully integrated care model where a psychologist goes in with anesthesiology, with physical therapy, nurse. I think that's it. We all go in together and we meet with the patient, and then we make decisions collaboratively with the patient about which one of us do they need the most in that moment.
Yeah.
And I think that's just the state of art care that we should be providing in the diabetes center as well.
Absolutely. Natalie, any thoughts?
We need to help our patients, the people that we see with diabetes, as a clinician, say, I want to know when every time you come in, what the hardest part about doing this is for you. Right? So like when you say to someone, how's it going? What do you say, Tom? Fine.
Well, yeah,
fine, everything's fine,
yeah,
right?
every time we do
you
say that, but really deep
Yep.
down is
So
not.
right. So the thing is, it's more about the idea that, like, tell me about the one or two most challenging parts. And sometimes it's going to be my toddler falling off, or my sensor doesn't last the full 10 or 15 days, or something that isn't psychological.
Yeah.
But sometimes it turns into psychological because it's so frustrating, and then I have to call, and then they don't ship them, and right?
Yeah.
And sometimes it's, I'm really struggling at work right now. I've had 2 really bad lows in the middle of the day. Wow, that must be hard for you. Tell me how that made you feel. Right? So it opens up conversation. I think asking, so how's it going, is the worst question that someone can ask someone with diabetes. I think we need to reframe it as, diabetes is really difficult. And so tell me about the 1 or 2 most difficult things, and tell me about 1 or 2 victories that you've had since our last meeting, or we set those goals before they walk out the door. Our goal last time was this. How'd it go? Right? Where are you? What's going on? Have you, because
when you say it like that, I totally agree, because by saying, I can see why we say it's nice for someone to say, how are you okay, how, whatever. But when you put it into that sort of context, how are you, are things okay, is potentially a closed question where you're potentially going to get someone that's going to say yes or no, and they're more likely to say yes. But if you allow them, if you ask that open question to be like, oh, you tell me a couple of most challenging things, or the successes, or whatever, you're putting the power in them to open up and kind of take that consultation, right, and lead it in the way that they need it, right? Does that make sense?
Right. Diabetes is hard. Tell me about the hard parts, and tell me about the things that have become easier over time, even, right? There are things that become easier over time. I know when I need to get to the drugstore to get more insulin. I've stopped, right? Like, I know to carry extra stuff with me. I know, right? All of those things are, right, should be considered victories, right? It is you, so there's that part of it, right? The second part is, I keep threatening to go work with Michael Harris or some of our other friends like Jill Weisberg Ventral, because they do have lots of psychological support, because their systems have bought into that. Right? They realize that psychological support improves outcomes. Not all systems have. We see it with the peds here. So our pediatric endo that's in charge here, her name is Jamie Wood, and she's the most phenomenal endo. Like, I love her. She and I get along. We have this transition program. We do all that. In adults, it's a little bit different, right? There are not enough adult psychologists that truly know not only just chronic disease, but, specific to diabetes, or specific to type 1, or specific to type 1 with complications. that exist. You know, I have one here in our practice that we use a lot, but she doesn't have the capacity to see everyone, right? I mean, I've got, you know, a dozen providers across different sites. And so there, it isn't what it should be, right? I mean, truthfully, it isn't what it should be. So that's a real challenge for us. Like it really, really is. It's a real challenge for us. So, you know, it ends up being that like if it's as it gets more critical, you know, those become more, but we do try to screen. We do use PHQ-9. We do, you know, to try to get to the people before it's, you know, like things are really bad.
Before the fire.
You know, you're right. But I will tell you, in the United States, it for people have to pay a copay for it too, right? So it's not always free. It's not always close to free, and so that becomes another challenge all by itself.
Can I just come back to something you all said that I think is really important to highlight, and that is just the entry point in an encounter in the clinic. I don't know that everybody takes that as seriously as they should. And I couldn't agree more with both of you around the entry point being kind of the beginning of a really important exchange. And so my strategy is the entry point is to not talk about diabetes, to talk about something more social, about, you know, a game that was on that everybody was watching, or the weather, or something like that. To not lead with diabetes. But then to Natalie's point, I always lead with, you know, this is a slog. And I'm really interested in hearing from you about what's working for you right now. And the reason that I start with what's working is that what I see in clinics is that most people find clinic visits to be quite punishing. You know, there's a kind of a problem solving mentality. And so we're really kind of looking at where things are. There's, you know, investment in numbers and ranges and those kinds of things. And so I want to start that encounter off on wins. What are some wins you're having? Because there's plenty of wins in diabetes management. There's also plenty of losses. And if all your encounter as a healthcare professional is around losses, you know, I want that person to leave feeling better than when they came in. And I can only do that by making sure that they have a chance to tell me their story, but also have a chance to highlight what is working, because I guarantee you, everybody has something to share that's working.
Yep. I love that. I do.
Absolutely. And that could be simply getting out of bed and just, you know, taking your insulin and, you know, taking your diabetes kit with you, or it could be anything.
It's even you know, more, well, yes, exactly. But like a patient who shows up 20 minutes late, you know, the first thing I say to them is thank you. Clearly you are invested in your health, that
they turned up,
whether the traffic or whatever, and you made this appointment under, you know, challenging circumstances. What the healthcare system provides them with, either a cancellation because they showed up late, or, you know, having to wait extra time to see the provider because they were late, or somehow being chastised for being late. And so I reflect to them that, you know, you obviously made this appointment, which means to me that this is an important thing for you, despite all the other challenges in your life. I'm impressed by that. Thank you for coming here. Thank you for being here, despite, you know, what's going on in your life.
Do you think if you don't get the mental health aspect right, then everything else can have it like a toll? Like for me, I think the mental health of just general mental health is so important. And recently, in the last couple of years, I think my diabetes, you know, I think if you haven't got them sort of things right, then you will struggle, or will have struggling points.
I think anyone who's a clinician understands that in spades. And anyone living with diabetes understands that in spades. The problem is that most of the funding organizations around, you know, diabetes tend to be focused on cure, tend to be focused on tech, tend to be focused on, you know, the next shiny thing. And mental health is not sexy. It doesn't sell like some of these other things. And so while I feel fortunate that we have psychology in our diabetes center, in some ways we are window dressing because we have way more educator. We only have, I think on the peds side, 0.3 FTE. So that's a day and a half of a pediatric psychologist. We have over 1,500, almost 2,000 patients in our diabetes center that are kids.
Wow.
So that a day and a half of a psychologist for almost 2,000 children. Like, if you look at the number of educators in our diabetes center, there's on the peds side, there's probably 6 or 7.
Yeah.
So, once again, I'm not trying to diminish the fact that our institution saw value in this, but I think once again, you talk to people living with type 1, this is a really important piece for them, but the healthcare system isn't reflecting that back. Our research isn't reflecting that back. And it's frustrating.
Yeah, absolutely. Quick question before we move on to your sort of section. We had a question come in. What is diabetes burnout, and is there a difference between diabetes burnout and diabetes distress, and are there different stages in the sort of burnout?
I have some thoughts, but I think Natalie probably should take this one.
Go for it.
I mean, I think we could both do it, right? So,
Sure.
there's the clinical descriptions that we will use when we're writing for a medical journal or whatever, right? And then there's the actual discussion that we're having with the person in front of us, and they use them interchangeably, right? So, I mean, burnout tends to be right where you just can't do it, right? You're just done, and you are, it's a burden of managing diabetes, right? That's distress, right? And burnout is like exhaustion, like you're done, like your tires, the rubber on your tires is gone and you can't go anywhere because the rubber's gone. That's burnout. You're at a loss. And people say, well, right, do you love that when they say just take your insulin? Well, if you just took your insulin, if you just put the CGM on, if you just wore the pump, if you just, and that burnout comes when that that's what you're supposed to do because 18 people have told you that, but you can't do it. It's like there's just there's a break, right? Where distress is more like that emotional burden of managing diabetes. It's like, I have 98 things to do today. 36 of them are diabetes related, which includes, wow, does this lunch taste a little bit sweet because someone brought in some, stir-fried vegetable, but it tastes a little sweet. Should I add 5 grams or 12 grams? Should I add 15 grams? Am I going to start beeping at 215? Am I going to, right? And like, you just kind of get this burden overall, but you can still do it, right? Where burnout is, you're really struggling with doing it and can't do it.
Wow.
I would just, I totally agree. And I would just add that I see distress as very dynamic, that people move in and out of distress multiple times a day.
Yeah.
Because diabetes, doesn't behave itself all the time. And when it misbehaves, that then causes a level of distress, which is understandable.
So is distress more the temporary, like in the moment sort of temporary thing, whereas burnout is a build-up of weeks or whatever, like a period of time?
Yeah, I see burnout more as a temporal issue. And I agree wholeheartedly with Natalie that, there's the more clinical definition and then there's what we see in the clinic. And so for some people, burnout may be, 2 weeks of really, really struggling. Someone else could be months of really, really struggling. So it varies wildly from patient to patient.
Thank you so much. Great question, great answer, guys. So for this next section, I'm going to hand over to you guys, and I know you've got sort of 4 sort of points, but we'll see how far we get in the next sort of 20 minutes or so. But I know, Michael, you're going to talk about the wins in diabetes are the behaviors, not the outcomes. Talking about numbers and evaluating over time and the challenges, the life challenges. how to manage the instinct to fight diabetes, avoiding that psychological quicksand, which I made reference to earlier on, and then talking about emotional and analytical aspects of diabetes. So I will hand over to you, Michael, because
Sure.
I'm sure it's going to be really enlightening. If anyone has any questions, please put them in the chat, and then we can bring them back later on. So over to you.
Yeah, and I'll pause periodically where, either Natalie and I can have a conversation, or, we can have others join in.
Sure.
But, why don't we start with, the concept, because we're kind of having this conversation about, clinic, and there's two concepts that really, well, three that fit for a clinic visit. And I've always thought that, it's odd that we have, these publications that, there's 42 things that can affect a blood sugar, and many of those things are outside of someone's control. Despite that, when people come into clinic, the focus is solely on their numbers, right?
Yeah.
Either time in range or A1C or whatever the variable would be. And so I've always thought that the most important part of diabetes is, doing the things, the behaviors. There are three primary behaviors, and they are, insulin, blood sugar management, and carb counting. And it's kind of like losing weight, that I tell somebody who has diabetes, or a parent who doesn't have diabetes, like, what would happen if I asked you to lose weight and I asked you to get on a scale, 5 times a day? Or what if we had a continuous weight monitor instead of a continuous glucose monitor, where you could see your weight fluctuate from second to second, moment to moment? Like, how punishing would that be? Because one of the things we know about weight is that your weight fluctuates from moment to moment, and it can be wild. It can be all over the place. It has to do with, what you eat. It has to do with water intake. It has to do with a lot of things, your metabolism. And so by getting on the scale repeatedly, that's the equivalent of how we look at diabetes management. Is you're constantly looking at blood sugars. Am I doing the right thing? Am I, have I done all the things correctly? And just like with diabetes, we know that you can do the same thing on 2 different days and get 2 different outcomes. And that's really psychologically one of the most challenging things from my view of managing diabetes, because that causes a sense of lack of control, and it's really frustrating. And so what I encourage patients to do is to consider that any diabetes related behavior is a win, regardless of what the outcome is. And the more you do the things, the more you do the behaviors, the more likely you will get the outcomes, but the outcomes are longer term. Back to weight loss again. There are 2 behaviors in weight loss: eating right and exercising. Will the scale show that in 1 day, 2 days, a week, a month? I don't know. Long term, will it show it? Of course it will. And so thinking across, in the moment, which is where most people with diabetes live, because they're constantly reminded of their diabetes, that the behaviors are the wins. And getting people to shift out of this is really hard, because clinics are set up to focus on the outcomes. People who live with others who have diabetes, they focus on the outcomes, right? That's where most of the attention is paid. And so educating not just the clinic staff and the healthcare providers to shift their focus, but the loved ones who are living with somebody who lives with type 1, to focus on the wins as being the behaviors. Once again, any diabetes related activity is considered a win. And that way you log a hell of a lot more wins than you do losses. And we were talking about diabetes stress and diabetes burnout. I think this is one of the things that can buffer you from burnout. Because otherwise, if you're just immersed in the outcomes, then you start seeing it as futile. Like, what's the sense? I'm working my ass off here, and these numbers just aren't cooperating with me. And then you get burnt out. Natalie, any thoughts? Anyone else, any thoughts?
I'm going to give the audience a chance real quick first.
Let's have a look.
Does this resonate with anybody?
Gillian, Mark, Kez, Rich, Claire, anyone want to, let me see, Kez, anyone want to come up to the mic, say a thought in response?
I've got to say, because I know so many the old timers I'm here, not quite you always talk about how before we used to go to
Mark, I don't know if the connection's a bit it's not coming through unless it's my end.
That's the problem. I can't.
No, I'm having the same problem with Mark breaking up quite badly.
Mark, maybe jump off, come back.
He doesn't know much about Contain, but I'll be back.
Yeah, that's fine. Gillian, we'll come to you. We'll come to you, Gillian, and then Azra.
There's probably not much point me commenting, because what am I now, 5.5 years in, and I still haven't had a proper clinic appointment. Maybe there'll be one in May.
Azra?
Yeah, I think I'm going to say I've lived with this. In March, it's going to be 38 years. But the first 5, 10, 15 years, I have no clue what was going on, even though I was an adult. I went through all the motions of testing and pretending to test and give my charts to the doctor, but it was always number oriented. But what really resonated with me right now is the aspect of the caregiver. 4 years ago, when my daughter was diagnosed, my perspective really, really changed. I became very active myself with the advocacy side of it. But not just that, it's how do I frame it? Because I know how it was framed for me. And I didn't like it. My mom is a qualified MRCOG, UK qualified, blah, blah, blah. My dad's a pediatrician. And yet the burden was too much for me to handle. And even though she's an adult as well, my daughter was diagnosed at the age of 23. I still will take over anytime she doesn't want it anymore. And I'll say, okay, what do you need? And we don't even live in the same country. Yet, what you just said about the caregiver not stressing, and I have to be so careful every time I call her, and I speak to her almost every day. How's your sugars? I don't want to ask that question, but it is there. That's the one thing that's at the back of my mind. And when I see something, I follow her number. So when I see something going on, I am thinking, what did you eat? Did you have pasta? Did you have pizza? I mean, these are the things that are, and she does feel judged that I said, I might ask, what was in the plate? And, she does feel judged. I know she does. So, yeah, that's my 2 cents. And I don't know how to go about it in a constructive way where I don't damage the relationship we have and yet be supportive of her. It's a hard line.
Let's bring you back to Natalie and Michael, your response and your top tips, and then we'll bring in Kez.
So I think the biggest thing is we have to make sure people, not just children, but people with diabetes are people, right? They're first people, and they might like chocolate, or they might like extra mac and cheese when it's delicious, or they might want, my husband will eat roast in Yorkshire until he can't actually stand up. Every time we go to the UK, that is his thing. Sunday, he wants Sunday every day the whole time we're there, right? And I think that we have to remember that sometimes the joy is about joy, and the high glucose, we don't focus on that, right? So when I used to do a lot of work with children with diabetes, and every time he goes to the mall, he's high. Okay, so he can't go out with his friends anymore? No. So what you say is, did you have fun with your friends? You did. Tell me about it, right? What did you do? Oh, we watched the girls. We ate lunch. Da, da, da. I want you to go back again. When do you want to go back again? I want you to eat the same thing again. And I want you to do what? Take more insulin. What did you take? 10? Let's try 14. Right? So instead of, and I want you to have a ball, and I'm going to give you the money I'm going to pay to do it. So every time you go to the mall, you can eat one thing and get really close. And then we'll add the next favorite thing and then the next favorite thing so that you're building on a positive outcome. Number one, did you have fun? Number two, did you enjoy it? Number three, tell me about, okay, now eventually let's get to the diabetes and say, all right, so every time you go, we need more insulin because you get to eat more. And I want you to eat more with your friends. I want you to have whatever, right? It's not about, because your number, we don't judge you when you put more on your plate. We don't judge you when you take the biggest pizza that there is, but you only had one piece, but you got the biggest one, and that had more carbs than the littlest one. I take the biggest one every time too, right? So I think we have to reframe it as creating success. First, talk about all the wonderful parts about what happened. Did you love it? Did you have a good time? What went on? And now, okay, so when we eat whatever it is, Indian, when we have butter chicken with rice, we need to give more insulin for that. Let's write this down and do 12 instead of 8, or do 4 instead of, whatever, right? Whatever the numbers are. And we really need to think about it as finding a way to thrive with diabetes instead of guilt with diabetes. Because you do feel, she feels bad, you feel bad, they feel bad, we all feel bad. Okay, great, now what? And then we start creating that distress and that burnout, right? Because you can never do it right. Or you can only do it right on Tuesdays if you stand on one leg and the wind is blowing south and it happens to be raining, right? That's not enough. That's not enough. So some of it is joy, and some of it is just enjoying yourself and saying, I'll catch up in a little bit and life will be okay. No one's expecting numbers to be flat all the time. And I think some of it is also the online community. You have a day where you're succeeding in your time in range and you're at 96%. So you put it online. So you see all these people with 96%. You think that's normal every day. I don't have that every day, right? There are days where I have more time in range than less, but I don't have it every day. And I think we all need to realize that type 1 is so many things. Like Michael said, that Adam Brown 42 factor, we pass that out in our exam rooms. We give it out like water here. Everyone who wants one can have a copy. There's piles of them. We print them in color on purpose because it is frustrating.
We want more, Natalie.
Because even my husband said, yeah, my pancreas up and ditched me one day, and I have to take insulin now. And sometimes I do it and my number's right, and sometimes it's not. And I think we all have to have that attitude when we're talking to the people that have diabetes around us.
I would just add, I love all that. I would just add that, Jill Weisberg Batchelor always says that you as a parent are not allowed to ask your kids about your diabetes the first thing that you interact with them in the day, whether they come home from school or whatever. And then I add that there needs to be 5-to-1 ratio. 5 questions or interactions around something other than diabetes before you get to 1. So that, we know that from the literature on successful marriages and relationships, is that it's a 5-to-1 ratio as opposed to an absence of conflict. It's the greater preponderance of the interactions are positive. And so I would say it's, you of course should be able to talk to your daughter about her diabetes, but you really need to load it heavily on the front end with non-diabetes related things to remind her that she's a person first, and that she has diabetes is just one part of her. The second thing that I may do is anytime she brings information to me, I say, this is great, regardless of what it is. Like, this is great. It's great to know this. Now let's dig in and let's see what we can do with it. So rather than the reaction of, your number was what? You say, oh, that's great to know. Let's pick that apart. Was this something, do you think that we had control over? Do you think this was just one of those things where diabetes was misbehaving? And so if the reaction is counter to what she potentially is getting now, then she's going to be more likely to share, that you're excited to hear the truth about what's happening and that you're engaged fully as a problem solver with her.
Azra, do you want to comment back?
Yeah, that's wonderful. That's the constant, in my time, my parents had nothing to follow. They only asked me, how are you? And what's the blood sugar? And I don't think I ever even told them every single day because they were working hard. I barely got to see them anyway. But with her, it's in my face as well because it's on my phone as well. And I wouldn't not have it on my phone because all the other things that I do need to follow, and I do want to be there for her. But yeah, I love it. I'm definitely going to put 5 questions, 5 to 1. I like that. I was doing 2, 3, and then the diabetes. But she knows. If I'm calling her, she knows it's coming. That's just it. But thank you so much.
But if you lead with, once again, the information being good, because that's really what it is.
Okay.
The information isn't bad. We want more information, right?
Yeah.
So anything she shares with you, or anything that's on her CGM, whatever, however you're getting information, like I would assume that's good, because the more information we have, the better we can kind of problem solve of how to change things, how to make things better. And so she needs to hear that you feel good about what you're seeing. Like, this is good to know this. And then ask her in a collaborative way, do you think we need to make any changes given what information we have in front of us?
Yeah, thank you. Yesterday,
The
her
other thing you can think
conversation-
about is
yeah.
doing it once a week. Instead of doing it the minute they walk home from whatever, from school, from
Yeah.
college, from being out, if you do a download and review it, you have an agreement once a week, every other week, whatever you're going to look at, and then you're able to say on Sunday nights or whatever night, right?
Yeah.
We're gonna do this together. Here we go, da da da, right? I think that you're in a better place because it left the time when she was gone on Tuesday when she knows, she already can figure it out. Now you're gonna go to 5 questions. Guess what she's gonna say? Here she goes with the diabetes again. Here she goes. I can feel it coming on. My mom is a pain. So if you did it on Sundays and you're like, look, I remember now, you were out with your friends on Tuesday and here's you spike from that. So let's just give some more insulin, right? And make it very casual and not about how many bites of rice or whatever she stood on or whatever. Like, she's worried about buying another red sweater and what boy's walking by. She could care less about her diabetes at that moment. And so some of it's just, maybe we need more space even than just even that day. Maybe it needs to be once a week where you look at the patterns, right? Yeah. Not the night of or the day of that wonderful thing happening, because you're crushing the wonderful thing in her world, right? You are. Yeah. So we have to kind of go, all right, how do we not crush her wonderfulness with the question of, because it really doesn't matter what she ate, it's already in her system. You can't take it back, right? So what if we just did it 4 or 5 days later and then made it that we finally treat the number the way we want to and get it down eventually? It's a lifelong pattern of this. Like, this is not today. We don't have to fix today, you know?
Perfect. I think I'm going to keep that on board. And I know all of us here, especially those of us who were diagnosed in the 80s and the 90s, we had it a lot more personal than what the younger generation have it now. It is out a lot more in the open with the CGMs, which is a good thing. I would never not have a CGM, but definitely it's taken off all curtains, so as to speak.
Thank you so much, Azra. Let's bring in Kez before we go back to Michael and Natalie to maybe finish the last section. Kez, did you have a thought or question?
Yeah, I think I was just listening to what everyone else was saying, really. I think part of my trouble was that although I was diagnosed as an adult and was asking for education, and we obviously hit COVID, I felt that because there was no one really to speak to, there weren't in-person appointments, I hit distress very quickly, and burnout, I would say, probably, to be fair. Despite the fact that, we had these online spaces to be able to reach out to. And I think my journey to coming onto a pump was very much, which you don't tend to hear a lot about, was very much due to diabetes, distress and burnout. Because people were looking at my numbers or talking to me about my numbers on the phone, as it were, and saying, well, what are you worried about? You know, you've got a great HbA1c, you're in the green, but they weren't asking questions about what it was taking to get there. So yeah, that still does stay with me now. Obviously, having had education some kind of 3.5 years nearly, maybe 2.5, 3 years later after my diagnosis, it was difficult, really hard.
Thanks, Kez, for sharing. Michael, any thoughts on Kez's points?
I feel for you. I mean, being diagnosed during the pandemic, wow, I just can't even imagine what that might have been like for you. And so, yeah, I really don't have any other thoughts about that other than it's hard enough to do it, when you have in-person care, when our world isn't shut down, you have access to other people for social support. But then you add, a diagnosis on top of that of like type 1 diabetes in that kind of an environment where everything is shut down and you are isolated and you don't have access to in-person care. And that's a tough beginning to a tough medical condition. I'm sorry that you had to deal with that.
Natalie, any thoughts as well before we maybe finish up with one of the other points of our main chat?
No, I think that that's really, this is hard, right? I mean, and you can't imagine being isolated. Thank goodness for the online community, right? I mean, I can tell you guys that, when the diabetes online community first started, clinicians, prescribers, because I kind of cross both sides, because I have type 1 and participate in the online community, I was less worried. But there were people who truly were terrified of what the online community was going to tell other people, right? Like, and that they were going to get tainted information and it was going to be terrible. And what we've of course discovered is it's saving people's lives, right? So to be able to reach out, even if it's virtually, I mean, short term at least, right? And there are diabetes meetups, right? I mean, I did a moms group this weekend of moms of kids with diabetes that's recurring all over the United States right now. And the moms are thrilled, right? Like, so I think that the more things you can show up for live, whether it's a breakthrough type 1 walk, even if you've raised $1.29, I don't care. It's about going there to see other people living with diabetes, and that everyone's number isn't 5 all the time, and everyone looks different, and it's all okay, and diabetes looks different with different people, right? I think that is, as quickly as you can, getting out to do as much of that as possible helps a lot. I really do. And then, as we talked about when we met Tom at the diabetes conference, Tom was on a Tom, do you want to talk a little bit about that, about the scholarship that you went under?
Yeah, well, Azra, Mark, Kez, Tony, Claire, who are listening tonight, we are part of the DDoC global community, and we're advocates from around the whole of the world, which is just fantastic that people who are coming together with a common interest to come learn and network and go back and pay it forward and take back the knowledge and we have these fabulous opportunities to connect with people just like you guys and learn from each other, and that's what it's about. Like you said before, nothing about us without us, and it's about paying it forward and trying to in my eyes here is trying to help other people that the support I never got, or the things I never had or experienced or knew about, or had peer support, or had opportunities to learn about or technology. By me being able to do a little bit like this and pay it forward, is if I can help one other person, then that's what it's about, and being part of that global community. And what I inspire about DDoC is that because it's a global community, people from all over the world coming together, is I was speaking when I went to ISPAD to some of the lads from Uganda and countries like that, and I was just literally blown away how it's a different world in comparison to the UK. And I know a little bit about the States, but it was just really fascinating just to hear I'm really sad the disparities and how things are so different, but they just had beautiful smiles and they were so upbeat and they just wanted to, like me, be there to pay it forward. So yeah, anyway, that was
I just want to say I have to run to another meeting, but I would just want to thank you all. Thank you, Tom.
Michael.
Thank you, rest of you all at Diabetes Chat. This is incredible gift that you offer people living with type 1, and you offer professionals to come share some of the experiences from their side. So thank you so very much. And I would gladly do this anytime you would like me to.
Thank you so much. 100%. We'll reconvene after Easter and stuff and try and set up another one, because there's so much more we can talk about, and you can see people are really learning and loving tonight's chat. So thank you, Michael, and Natalie as well. Your lived experience, your amazing knowledge as a clinician as well. It's been really, really insightful, guys, and it's a bit of therapy, just people coming together, talking, sharing, and what I've taken away from tonight is talking is so important. We don't want to get to burnout. We don't want to be having to put that fire out. We need to be helping throughout, and we need to put things in place. There are challenges with type 1, many challenges, like you said, the 42 factors, 180 decisions every day that we're making. Is that balancing act, isn't it? That you're juggling all your diabetes stuff as well as life, like normal life, and getting up for work or school or college or family or whatever, or in just joining life. And I think what I've taken away from tonight is them other things that you highlighted, Natalie, and Michael highlighted, is the key messages here from my point is having that conversation, not just saying how are you, how are things, but then tell me, like, what are the challenges in your life, or what are the successes, and I think that's really important as well, having that success and the ratios, as Michael said, 5-1, the conversations, and just ultimately, I think just giving ourselves a pat on the back, because we're living with a complex condition that's ever changing every day. No 2 days are the same, as you said before, and I think, come on, man, like we're doing the best we can, and if we get 70% time and rage, wow, phenomenal, absolutely amazing. If you're not quite there, then you keep going, or whatever. And if you're having I don't like to use the word good and bad days, not at all, but to put it into context, if I'm in the spell that I'm not particularly happy with, it's a bad spell for me, say, is my good friends Rich, Claire, the community here is, and I say it back to these guys, is tomorrow you start again, and that's all we can do. As soon as midnight strikes, start again tomorrow and try again. And if tomorrow is not still good, try again the next day. And if it's a week after, try again. And do you know what I mean? Like, for me, like I said before, it was 15 years before I even accepted my diabetes, started taking things more serious. It was mainly because I had 2 children, and it eventually hit me, to be honest. But what a chat. I probably just rambled on there to kind of summarize tonight's chat. But Natalie, I'll give you the final words.
No, I think you hit it on the head, right? This is pretty complex, and it's pretty hard, and it's, I think there seemed to be, when I am in an office with a person with diabetes in front of me, right? Some of it is just like some of it is just the idea of talking about how difficult it is and how much this stinks. So it's like some days it stinks a little less, but it still stinks. And some days it stinks a lot, right? And that's kind of the levels, right? Like That's what we're getting to. We're not getting to the, you know, the stuff in between is the hard stuff, right? So I think that in between is where where we tend to struggle just in general, right? So, you know, I do believe that yeah, that's really where we are, and we're allowed to admit that and talk about that.
100%. Yeah. And it's okay not to be okay, and it's, you know what I mean, it's important to talk and reach out and connect with peers and clinicians like you guys. We shouldn't be alone in this journey. We're stronger together, and yeah, it's so important. Thank you so much, Natalie. It's been phenomenal. We will have to connect up and do it another one. As you can see, the community loved it and really interactive as well.